This week on the BackTable podcast.
I think you need an experienced cytopathologist who then I think cytology is a very, very good tool. We'll get into, I guess, biomarkers later.
Yeah, absolutely. We're going to talk about that. So just for the sake of our audience, so you guys are doing barbotage cytologies. What fluid are you using for your cystos?
I'm using saline.
Yeah,
I think that's an important point for all the barbotagers out there. Don't use sterile water.
Sure.
Yeah, it's interesting. Just on cytology, another side point is, so I see patients at lots of different clinics. And when I'm at Keck at the main clinic, those cytologies go to our trained cytopathologists who really specialize in urothelial disease. Some of our peripheral clinics, they go to, the Quests and the whatever. And I find that the quality of those readings is exceptionally different. And so I think that, to your point, really having somebody where you feel confident about their reading is very, very important.
Welcome to the BackTable podcast. I'm Bogdana Schmidt. I'm an assistant professor at the University of Utah, and I'm so excited to be here today with Dr. Anne Shuckman and Dr. Piyush Agarwal. Thank you so much for being here.
Thanks so much for having me.
Yeah, my pleasure. This is wonderful. Thank you.
We've got a lot to cover. We're going to talk about contemporary strategies in non-muscle invasive bladder cancer diagnostics. This space has become much more complicated. Some people are doing tests I certainly wasn't aware of when I was a trainee. So I want to focus on where we were, what I'm used to doing for my patients, and maybe you guys can tell me what we all should be doing that we may not be aware of. So let's get into it. Piyush, can you run through what your approach is for a new patient with a new non-muscle invasive bladder cancer diagnosis? Do you start with a risk stratification system? How do you approach that?
Yeah, that's a great question, Bogdana. I think when I first started practice, I didn't do any of this. And I basically just, if they had low-grade disease, I wouldn't do any other treatment. I would just follow them with cystoscopy. If they had high-grade disease, we would give them BCG. Now, I think it's very important to do risk stratification because I think there is an entity to intermediate risk disease where it does behave differently than standard low-grade, low-risk disease. So we will risk stratify. I basically, in my mind, anybody who has low-grade that is a single lesion is a low-risk patient. Anyone who has high-grade disease, in my mind, is high risk. And then any multifocal, highly recurrent, large, low-grade tumors, I throw into intermediate risk. Where I differ with the guidelines is I know TA high-grade, less than 3 centimeters, some people lump into intermediate risk, and I don't love that idea. I think the biology pathologically should guide us more than an arbitrary basket of intermediate risk. But I think it's very important because that dictates treatment.
Completely agree with you. And that is part of the difference, I think, between what you see in the AUA stratification or the IBCG, EAU European classification system. And how about you? What do you do with your high-grade 3-ish centimeter solitary high-grade lesions?
Yeah, absolutely. I agree. I mean, to me, anyone who has high-grade disease or certainly carcinoma in situ is in the high-risk category. And, I think where it's become really important with these intermediate risk patients is just the concept of actually conservative management is so much more popular than it used to be. So you could say, yeah, those high-grade patients are certainly going more into the high-risk category, but I have also become probably more aggressive about just really watching some of the low-grade patients, even if they have multifocal or recurrent disease. You kind of get the sense over time of this patient has been recurring for 3 to 5 years, kind of periodically, and I really try to limit my intravesical therapy or other treatments in those patients.
And for patients like that, what is your surveillance schedule for them?
Well, some of it is based on their anxiety, I think, so I will start in those recurrent patients with saying, why don't you come in every, 3 to 4 months? And I'm pretty lax about that. I try to give them a little bit of a longer leash than saying, okay, you just got to come in every 3 months, because I think if I'm that strict, it actually increases patient anxiety. And then after maybe a year of that, I really go to every 6 months. And, and I do try to keep them on an every 6 month schedule for several years.
Perfect. So with that, we've talked about cystoscopic surveillance, really trying to get the stratification going. Are there any other tests you order for a new patient coming in? Any blood tests, any urine tests, new diagnosis?
The first cystoscopy, I will do a cytology. I think that the data has changed so much on really how effective that is, how useful that is. But I do send that, no question. I can't lie. I send a basic CBC and CMP just to check, their renal function, but I don't do any other special blood tests at this time. And I don't use any other urine markers, in the upfront situation.
Perfect. Piyush?
Yeah, I would agree. I pretty much do what Ann does. I think cytology, the one thing we do that's different, I think, than other places, we'll do an instrumented cytology.
So bladder washing barbotage?
Oh,
we'll do bladder
we're
wash.
certainly
You're doing that
yeah,
as well?
Absolutely.
Okay.
I don't send avoided cytology because I just find I don't think it's very useful.
I agree. And it's surprising a lot of places do still use avoided cytology. And I feel that, your cellular yield is poor. I also feel that if I see an abnormality, if I'm just sort of barbotaging right on it, I feel more confident if it comes back negative for high-grade disease. Our pathologists are really good at not calling a lot of atypicals. And I think that's where people have lost faith in cytology, when you get a lot of atypicals. So I think you need an experienced cytopathologist who, then I think cytology is a very, very good tool. We'll get into, I guess, biomarkers later.
Yeah, absolutely. We're going to talk about that. So just for the sake of our audience, so you guys are doing barbotage cytologies. What fluid are you using for your cystos?
I'm using saline.
Yeah,
I think that's an important point for all the barbotagers out there. Don't use sterile water.
Sure.
Yeah, it's interesting. Just on cytology, another side point is, so I see patients at lots of different clinics. And when I'm at Keck at the main clinic, those cytologies go to our trained cytopathologists who really specialize in urothelial disease. Some of our peripheral clinics, they go to, the Quests and the whatever. And I find that the quality of those readings is exceptionally different. And so I think that, to your point, really having somebody where you feel confident about their reading is very, very important.
Absolutely. I think that's super important. So moving on from the initial workup, new patient, new diagnosis, what about imaging? What is your initial imaging of choice? Do you get cross-sectional imaging on everybody with the new bladder cancer diagnosis? Oftentimes they'll probably have it before they get to you, but if you get to pick, what do you order?
Yeah, if I get to pick, I order a CTU if their renal function is good. If they come with a CT scan just, with and without contrast or just with contrast, I accept that as long as everything else sort of is lining up to not make me exceptionally suspicious that there's an upper tract lesion that I'm missing. And if they come with something else, I'm not going to repeat that imaging just to get what I want generally.
I would say the same thing, unless it's someone who I am more worried about muscle invasion. If I say hydronephrosis, then I'll say, look, I definitely need a CTU. If you just have a CT scan, which is often, they'll come for a CT scan and there might be a bladder mass, then at the time of the TURBT, I'll just do retrogrades. I would try to do those retrogrades before I resect the tumor because I'm of the mindset I don't want cancer cells kind of floating up there, but I think a CTU is standard.
That sounds good to me. That's exactly what I do. I think that's very nice. What about MRI protocols? Do you guys have an MR urography protocol in your institution or not yet?
Yeah, it's surprising. We're so good with MRI when it comes to prostate cancer, but I think with bladder cancer, there's just very little appetite, at least among our radiologists, to really, into it very deeply. I've met some younger ones who are now interested, so we're hoping to get involved and look at VRADs and see if we can use MRI to stage bladder tumors. I will use it after trimodal therapy for bladder cancer because I feel that it really tells me if there's something hidden within the wall of the bladder for a recurrent muscle invasive tumor. But as an initial for non-muscle invasive disease, I rarely use MRI.
How about you, Ann?
I agree. Patients come with MRI, and I feel like sometimes it can be a pitfall because the data, if you read it, is pretty good, supporting, the ability to look at local staging with the MRI. But I feel that it's so user dependent in terms of the read. And so many patients will come and say, well, the MRI says it's not muscle invasive. And I'm like, well, you have hydro and literally the pathology shows, something very, very different or, a really concerning high-grade T1. And so I think that it can give patients a little bit of a false sense of security sometimes or try to have them try to limit the actual pathologic staging, that we need to do.
I agree. I don't think we're quite at staging with imaging alone for bladder cancer. So I do think that's a possibility. I think we could get there as our protocols get better, as reliability, inter-reader reliability improves. I think it's an interesting space to watch, but I don't think it's there at the moment. You wanted to talk about biomarkers a few minutes ago, so let's spend some time on this. I think this is interesting, and I think it gets complicated. So tell me what you use now. I know you said when you started it was cytology only.
I've experimented with a lot of different biomarkers. For example, NMP22 has a nice point of care test. It used to. The advantage of that test is that it has a very high negative predictive value. So one of my mentors, Bart Grossman, had done a trial where he had looked at omitting an annual cystoscopy in patients, with low-grade, low-risk disease if their NMP22 was negative. And that actually, I think, was a great strategy. So I think to Anne's point earlier, a lot of these low-grade, low-risk patients, some of those intermediate risk even, they get a lot of anxiety for TURBTs. So for some of them, I will just say, well, look, I'll do an annual NMP22 or an annual cytology and if it's negative for high-grade disease, maybe we'll skip your CISTO for the year and go to every other year for a CISTO for a low-grade tumor, low or even intermediate risk tumor that's low-grade. I think NMP22 is an easy test that one can do. It's available. I think there are some newer ones. We can talk about them. CX, Bladder, EpiCheck. I think they have some promise. The problem is the gold standard is cytology. And for cytology, for when you think about hematuria, having, someone with gross hematuria still has a very low risk of having bladder cancer. So cytology is great for someone as a biomarker for someone who, because you're looking for something with a high specificity. And I think for cytology, it's a really good test for that. I think for recurrent tumors, the problem is that you need something with a high negative predictive value and high sensitivity. And that's where cytology fails us. And I think all of these newer biomarkers, you started with Eurovision, and now it's moved on to CX Bladder and EpiCheck. I think these are improving upon cytology when it comes to low-grade, low-risk, and intermediate-risk bladder tumor. But it's hard to sort of dethrone cytology. I think cytology is still very good for the disease we worry about the most, which is high-risk disease.
So, Anne, I'm going to ask you, cytology in particular, if you have an intermediate-risk patient, are you using it for them or no?
So it probably depends on what the intermediate risk is. I mean,
recurrent low-grade.
Yes. So I try to stop myself from using it in those patients is the reality. I know that it's very low utility and I don't think we should be using it. And I try to get over my old ways and stop just sending it as a reflex. There was a really interesting study that I came across. And honestly, as I was telling Bogdana in preparation for this podcast, because I don't use a ton of markers in my practice. I use CX Bladder. I think that, we should acknowledge that in the hematuria space, they've done a really nice, actually randomized controlled trial, which there are, few and far between. But I came across another study called EuroFollow, and I don't know if you guys are really familiar with this. I was not, but they looked at sort of combining all of these different markers, in this intermediate low risk to try to avoid cystoscopy. And I thought that was sort of an interesting intermediate strategy. Maybe that's where we are. And I think they combine cytology, Eurovision, and maybe one or two other factors to decide, who was going to get a cystoscopy and not. And I think, going forward, some of those types of strategies where we're looking at a mutational panel, an mRNA panel, and different ways of attacking this to be able to feel like we're not missing tumors may become something, but I don't think we're quite there.
So some combination approach maybe to delay the cystoscopy interval, trying to factor in what biomarker we can use in this space. Absolutely. I think that would be interesting. I know during COVID, people did publish on using this biomarkers. I think Dr. Porten actually published on using CX in this space. showing the safety and feasibility of it. But I also feel like after COVID, a lot of us went back to doing what we were doing before instead of integrating some of these new approaches.
I use CX again. I go to this very rural clinic once a month. And so I've had to sort of change my strategy there because it's so different than practicing in the university environment. And many patients just don't show up for their cystos, and patients I'm quite worried about. And so I do mail them a CX kit if I can't get them in for, I feel like it's like, in a way, maybe it's better than nothing, but there is pretty good sensitivity, certainly for high-grade disease. I think that it can be a very, very helpful tool, at least also to convince patients sometimes that they do need a cystoscopy.
So let me ask you, you mentioned, Piyush, that you've got excellent pathologists and you don't get a ton of atypicals.
Yes.
But I'm sure every now and then they still come up. Do you use a biomarker in that space, or do you say straight to the OR? What's your approach?
My traditional approach is we will go to the OR, use blue light cystoscopy. We will do, if we don't find anything on blue light, we'll do random biopsies. We'll sample the prostatic urethra in men, and we'll do washings of the upper tract. And so in my mind, then we've looked at every possible source. There's a nice study CX Bladder had where they used CX Bladder to educate basically atypical cytology in the setting of an equivocal cystoscopy. So in those patients who were getting white light cystoscopy, they found that they were able to predict all of the patients, nearly all of them, that had bladder cancer with CX Bladder in the setting of atypical cytology. So I think that that is a good role for CX Bladder. I think that is something that I'm going to start adding to my practice to do that in addition to, what I described. And I think, I do have blue light cystoscopy in my office, but we do it on a certain day because of workflow. And, often I'm not doing it on the patient that I really need to be doing it on because they're not booked for it. So I think ultimately, I think that's where you can incorporate maybe CX Bladder.
I use CX in the same way, and I've used it for many years in that way, but there are several limitations, and one is you have to have avoided urine for CX. And so I find that, I'll be doing the cysto and I'm like, oh man, this is the patient where I really wanted that. And for a long time, I was trying to get avoided urine on everybody, but it just didn't stick. And then the other thing is that you can get a lot of no results if there's inflammation because they added in that inflammatory marker as part of their panel. So in the post-treatment setting, whatever, when I'm looking at it and I can't tell, I find that often CX also can't tell because of that inflammation. And so then I get really frustrated because I'll tell patients, well, let's see. And, then it comes back with no result. But I do use it a lot in that way and I find it helpful.
I think the workflow stuff is really challenging because for CX, you have to get the voided into their specimen container. Even if you collect the voided into your normal container, you can't just pour it into it. So you have to plan for it, which I also struggle with the planning aspect of it. So you mentioned that you do use blue light in the clinic. Obviously, you can't just decide you want it the moment that you want it. And do you use NBI? Do either of you use NBI?
Our scopes have NBI. I never use it.
Okay.
And we have blue light in the clinic and I use it, fairly often.
So whom do you schedule for your blue light clinics? Both of you. Sounds like you guys have it.
Yeah, so my patients who have a history of CIS are the ones I really focus on trying to schedule for blue light. The patients with papillary disease, sure, I do think it can help, and the data definitely would support that you can pick up more of those low-grade papillary tumors. But, if I'm trying to prioritize who's going to get it, I really focus on the CIS patients.
Yeah, that would be the same in my practice, CIS. I will, however, if I'm taking a low-grade patient with multiple papillary tumors to the OR, I will do their surgery with blue light because I feel that I'm better at not missing any tumors because sometimes the bladder is studded with, 20 little tiny tumors. And the worst thing for the patient is, seeing those tumors. So I try to get every little tumor out with blue light in the OR. But in the office, I agree. CIS is really the only one where I think you're really making a big difference. And for the papillary ones, only if the patient insists upon it. It's also very important for enrollment in clinical trials. So we have to find CIS in a lot of these patients to put them on trials. And so I think it's very helpful to do that so you can find the optimal candidates.
I'm curious, do you do a lot of, fulguration in the office and Is it more on the spot, or like, are you planning for those patients ahead of time to come in and kind of, those are some of the times I schedule for blue light, even in a papillary, when I kind of know I'm going to say, okay, we're coming in to do fulguration. Let's do a great job.
Yeah, no, that's a great question. Again, in an academic setting with, a lot of patients, we have a dedicated day for bladder biopsy fulguration. And so we'll do it. And I have in a handful of them done. It's just so hard to coordinate. If you think about it, the ideal situation would be you put in the blue light, you do the fulguration biopsy afterwards, and then you actually put gemcitabine in their bladder.
Yeah, right.
And that's just a lot easier to do in the operating room between, the pre-op and the PACU area than to do in your office.
Yeah.
So I think, unfortunately, we probably are not doing... Maybe I am not. I don't know about others, but I feel that is a hard thing to do in your clinic versus doing in the operating room.
I think the gem is a real issue because I always think about that too. I do in-office fulguration, not infrequently and almost never planning for it, but you see something in it, well, this is where we are. And I always wonder if I should be trying to get gemcitabine into that patient, but I can't do it in my clinic. I can't give him a chemotherapeutic in my clinic room there, and so I would have to send them over to the next room to AMU, and it never works out logistically. But
we could do it, but if you think about it, that patient's going to end up in the clinic for like 5 hours. Because by the time they go through the CISView and the CISTO and the so we don't give gem in the clinic, which is probably a disservice.
I think about that too. Well, maybe somebody's going to start doing it after listening to this. So you're doing cystos, you're doing blue lights, not blue lights, some fulgurations. How do you make your patients comfortable with cysto? What's your secret sauce? I know Angie Smith published something recently about patient experiences in this space. We certainly have some patients who we know are going to tolerate it great. We have some patients who are not. And of course, patient anxiety is a factor. So how do you make your patients more comfortable for this?
I wish I probably did a better job with that as well. There's so much great data on things like, acupuncture, and I don't have any of that available in my clinic. So when I have patients who are really anxious, but even they say, okay, I want to get through this, I don't want to go to the OR, I'll encourage them. In this day and age, everyone has a phone with music on it or something they can, watch. So I encourage them to do that. I try to remind them to do that. If patients have had a lot of, discomfort in the past, I will certainly have the nurse prep them and put in lidocaine and really let it dwell, because that is the thing patients say, like, oh, they jammed in the lidocaine and 2 seconds later put in the scope, and patients, I think, really don't like that. They know that lidocaine hasn't had a chance to work. So I try to do that, and I do think it helps a lot. I try to distract them. I show them what I'm looking at on the screen if they want. My PA is a really funny guy, so in those patients who are really anxious, he comes in and just talks to them while we're doing the scope. So nothing that is secret, unfortunately.
Each patient is unique, and everybody handles that anxiety differently. I'll give a shameless plug for a BackTable podcast that I'd done on music in the operating room, and we had cited some data that showed that for office cystoscopy, music actually does improve or diminish sort of the perceived pain or that patients have. So I do think that music is very helpful, and we'll just tell them, what do you want to listen to if that's an issue. I think, I'll have the nurse squeeze the fluid as I'm going through the prostatic sphincter or the urinary sphincter. I learned a technique from one of my fellows, just telling the patients to wiggle their toes.
Oh, I do that
too. So they don't bear down, and that really distracts them. It works beautifully. And I think those sort of things, and I'll make some joke, and eventually, they'll get through it. But for really young men, it's very, very hard to convince them. And sometimes we'll have to do it in the OR. And if they're really just too anxious, we'll schedule in the OR.
I had a male OB-GYN patient, and he was like, if you tell me to relax while I'm doing this, I'm going to be really upset with you. And he's like, I've done so many patient procedures and just told them to relax. And let me tell you, that doesn't work.
I've had a patient ask me why, maybe after a year or two of doing the surveillance cystos, as he was leaving, he goes, I have to ask you, why do you make me wiggle my toe?
That's so funny.
So getting back a little bit to talking about our tumors and what we see as cystoscopically, obviously papillary lesions, probably don't need NBI, probably don't need anything else. I find that the most challenging scenario is a patient who recurs post-treatment, maybe. So that post-BCG has made high risk patient in this case, where you're looking at it and you're like,
Yeah.
what do you do?
Yeah, I say, like Anne, I think, another thing about CISTO, we have the image connected to a monitor, and I think that's very helpful for some patients. And I tell them, I see some, red areas that look concerning. This could be, sort of persistent disease, recurrent disease. This may just be inflammation. So I try to just allay their fears, because there are some patients who are just, looking at that screen and, they will, if they see a tumor, they swear, they start crying. I mean, it's really, really nerve-wracking for patients. So I try to sort of say, look, this looks concerning. I think we have to evaluate it. And then after we're done with the cysto, I have them get dressed, because a lot of times if you're having that discussion while they're still laying on the table is not ideal. And usually they may have a family member who wants to participate. So we'll get them dressed, get them in a room, and then we'll talk about, okay, we did a bladder wash. We'll see what that comes back as. And but probably we should think about doing a blue light cystoscopy, doing biopsies. And this is where I think, I always think biopsy trumps a biomarker. So if I'm not going to do a biopsy, then I think we think about a biomarker. But if I'm going to do a biopsy, I think, just my instrument of cytology is usually what I do.
Yeah, same. And that might be a situation where, we'll get the cytology back right away, usually within a couple of days, but I might throw in a CX bladder and help make a decision about a trip to the operating room based on that.
So I'm going to ask you to describe in words what you see on a screen, which I'm sure is going to translate beautifully for our audience. But when you're looking at something, what gives you a hint that this is an early recurrence versus this is more likely inflammatory? Is it a specific look? Is it a textural? Is it a color? Is it when it's over a prior scar? Are there any visual cues that through your years of experience you've kind of garnered where you're saying, I think this one might not be a recurrence. I think this is inflammation. We're still going to do all these other things to check, but in your mind, what do you look for your own personal sense of reassurance? What do you teach your fellows?
Yeah, I think that's tricky, because I do think it's such a sense of things. But again, for CIS, I think that particularly with blue light in the clinic, really looking for sharp edges of demarcation is really helpful, because you can have all kinds of perceived false spots. When you look in with a flex blue light or even not, everything kind of looks pink, but if you move your scope and you continue to see those well-defined edges, I also really look for sort of a well-defined edge where, to me, it looks like all the vessels are blurred out. I don't know how to say it in any better way than that, where, I'm not really seeing, in CIS, I'm not necessarily seeing hypervascularity in that lesion, but more of a sort of a hazy appearance that is well-defined and that maybe weeps as the bladder is filled, a little bit of early bleeding. I mean, that's all really subjective, but...
No, but that's exactly, I agree, because those are all the things you're kind of thinking. That's why I asked you to put them into words, because it is a vibe that you have from it.
Yeah, I mean, I think the thing I have the hardest time assessing is patients who've had a fairly extensive TUR and really assessing the base of the old TUR site. So there, I think all bets are off. I mean, often it's calcified or fluffy, and I'm really just looking for papillary disease in those situations.
Yeah, I would say I agree with all of that. I think sometimes, people use the term furry or velvety.
Velvety, right.
I think those are applicable in some situations. If you are using blue light and you touch the area that's lighting up and you see particles floating around.
Scratch test.
Yeah,
yes.
that was scratch test. I think Sia kind of described that in a paper. That I think is maybe more suggestive of CIS. And I think, definitely bleeding. But I'll often use blue light in post-trimodal patients to look for non-muscle invasive disease. And that's where I think it's even trickier. So, let alone people who've been treated previously with intravesical therapy, I think even that space, it's even harder to get good diagnostics.
think part of that, and I know everyone has their own algorithm, but because of that difficulty, when patients have had induction BCG, unless they absolutely refuse, I take them back to the operating room for that first biopsy for my first cysto, particularly, really high-risk patients, because I don't still trust my visual interpretation enough, and I don't trust cytology enough. And so I'll go back in patients who have had extensive CIS particularly and rebiopsy them, no matter what, after induction BCG.
Do you find that patients, I'm sure both of you have experience with gemcitabine as well, do you find that the visualization is a little bit easier with that as opposed to BCG, the inflammatory reaction, or about the same?
Maybe a little better.
Yeah, hard to say. They some of these patients, the bladder just responds really, really aggressively to any sort of installation. So it's hard to say. But yeah, maybe the bladder looks less inflamed in gemcitabine, but that's very subjective.
Yeah.
And everyone's different. Everyone is so different.
I agree. I think that that's kind of part of the art of it in some ways, and that's why we need more objective data. That's why we're talking about biomarkers. That's why we're talking about repeat trips, adjudication, all of this stuff, because it is so subjective, and our patients want a little bit more clarity in this space. So when you are talking to the patient about it, their new diagnosis, their recurrence, their journey through this space, do you use any risk calculators in these conversations? I find that with bladder, I don't rely on a risk calculator the same way that I do for prostate consistently. And when I've tried to use the EORTC calculators, I find myself trying to explain what's not in the calculator and what it doesn't factor in more than I'm explaining why I'm using it. And so I've backed away from doing it consistently. Do you incorporate that in your counseling?
I do in some patients who sort of want a number. Some patients are just, your typical engineer, who is driven by numbers will say, hey, what is the percentage? And for those patients, I will. But I will set this up by saying, this is a lifelong disease, unfortunately, and, we'll probably grow old together, and we're going to be looking at your bladder very carefully, and you're going to have a high risk of recurrence. That risk is going to be highest in the first 2 years. The longer you go without a recurrence, the better off you're going to do, but we don't really know when to stop surveillance entirely. I once saw a patient who had a recurrent tumor 13 years after going with no tumor. So it's I think if you set them up for that, most patients say, okay, fine. And I tell them we will decrease the frequency of surveillance, and eventually this will be like, going to the dentist. Like, nobody enjoys it, but you get it over with and then you're good for a while. And so I think that's kind of the framework. But I do like the EORTC calculator. I think it has some merit. There's also a paper published in European Urology, Sukup et al., which gave a recurrence table based on what the initial index tumor was, and then what the risk of recurrence is at each month, like each 3-month interval after, and you can see a nice progression downward. So if patients are really interested, I'll give them a copy of that article and say, look at this article. But most patients, they don't want a number. They just want to know what is the long-term game plan.
And do you use anything else, or you kind of just talk about?
Yeah, I agree. I think we use risk stratification. I generally tend to use the AUA risk stratification and sort of talk about it just based on that. And I think like the EORTC calculator really incorporates all of those same factors just to put patients into risk groups. And so I do talk to them about what risk group they're in and what makes them be in that risk group. But beyond that, I don't tend to use a specific calculator.
How about if you could design a calculator? So with your experience, you talked about the risk stratification. So that's just the path, right? Recurrence. It doesn't give timelines. Like you said, some patients are going to recur 13 years later. We've all seen that. Or a patient who started with low-grade disease, some of them are going to develop a high-grade disease, small number, but it does happen. And sometimes it happens a lot later in their disease course. What do you think would be most useful in predicting that risk? So of course we know certain things, CIST1, right? Some of these very, very specific things are going to change categories, but
it'd be really nice to know upfront which patient is going to ultimately not respond to intravesical therapy. So Lars Driscott had a nice paper where he looked at some mutations of tumors in CIS patients, And he was able to predict those patients that were not going to respond to intravesical therapy by looking at a bunch of specimens from patients pre-TUR and then knowing their long-term history. And I think with ctDNA, I think we might be getting closer to that kind of prediction where we could tell a patient right off the bat, okay, you will do well with intravesical therapy and we should continue doing sort of our standard of care, or telling someone, look, you've got an aggressive tumor, a high potential for it progressing, like we do with T1, disease when it initially presents. And so you may want to consider early cystectomy or early trimodal therapy, although the problem is we don't really have good data in trimodal we have some data for T1 disease, and but not really for papillary. So I think I would say I would want some sort of prediction for who to give intravesical therapy for and who would do cystectomy on.
Yeah, absolutely. I mean, I think when you look at our current prediction tools, what's still in the calculators hasn't changed, right? Since, I don't know when, the 80s probably. It's truly still like stage grade. I think the European risk groups have age, some of those things, but it's still really blunt factors. And I think we're really moving into the next era where we're going to have molecular tests and we're going to have actual tumor specific information that is a lot more than just age and grade. I think that'll be the next step, no question. We were talking some about AI and the role of, Valor to be able to give us some of those predictive tools. And that's in its, I think, very nascent stages right now. But there is, obviously really provocative data. And I think that those things will start being incorporated into actual calculators.
So just to elaborate on that a little bit, when you say Valor, you're talking about the Vesta-Chai biomarker for BCG versus gemcitabine for treatment decisions.
Right.
Or are you talking about their little printouts, like the graph they give you for recurrence risks, or both?
I guess I'm talking about their, whether or not you're going to be BCG responsive, essentially, because that, I think, is the news we can use, right? That'll help us really get to the point where we're actually providing individualized, like patient-specific therapy, which, again, now we are starting to have more tools, right? Like we never had other medicines before. And so now that we have other therapeutics, it sure would be great to know who to give those therapeutics to.
So I know, obviously, this is something that some of us are using in clinic. I personally am using it, but are you guys? And are you using it to see it, or are you using it to guide your treatment decision?
Yeah, I mean, I wanted to ask you both a question because I'm not exactly sure how to use it. I've been ordering on a few patients. I'll give you a quick anecdote. I ordered it on a patient. And again, with the BCG shortage, I also feel like, especially with the bridge trial almost being accrued, and we might know the results in some time, but maybe from our personal experience, we may, I personally at least think gemcitabine is probably, not inferior to BCG. Of course, we have to wait for the results of the trial. But we used a lot of gemcitabine during COVID when we had no BCG, and we had similar outcomes. So when I order this test on a patient, it shows maybe a decreased, response rate to BCG. It doesn't decrease significantly, but decreased a little bit. So I told this patient, again, in the shortage of BCG, I said, well, we could just go with gemcitabine. They saw another colleague in town at another institution who said, well, BCG is the gold standard, and you should start with that until we know the results of the bridge trial. And again, I can't disagree with that statement. So I'm not sure, how to use a test. So I'm curious whether either of you would give gemcitabine, knowing if you use that predictive biomarker, or would you decide which intravesical therapy to give?
I don't have enough experience at this point. I haven't, we just have sort of incorporated the ability to send a Valor at our institution. I have yet to send one. So this is all within the last 2 months, 3 months maybe. So I can't say sort of from my own confidence. I agree, though, that as a treating clinician, I have just as much faith in gemcitabine as I do in BCG to treat patients. The problem, has always been, again, we don't know which patients, so some are going to do great with one or the other, maybe both, who knows. So at this point, I can't say I would, but I think it's something that is, as a treating physician, like the next thing on my horizon that I really feel like I could do to take the next step for the patient.
So I think one thing to consider is a lot of patients who you send it on are going to come back biomarker absent, right?
Sure.
It's going to say dealer's choice.
Yeah.
And so in those cases, I will just do what I'm going to do. And I think whenever we have a BCG shortage, whenever we're, at least in my institution, doing like half-dose BCG or anything like that, I will often favor gemdosing, because when we think of BCG being the gold standard, we're talking about full strength, 6 doses, kind of traditional. So if I'm ever in that scenario, then even I feel pretty good about it, and I explain it to the patients. This is why, this is what I think. I'd love to see more data. I'd love to see the biomarker in the bridge trial and looking at that. I think that's where we're gonna be. We're gonna have that data. But right now, I still believe in ordering the tests. I believe in gathering that data to see how we can best use it.
Yeah, and I think like any new tool that is like a completely new I mean, you can look at data, but every clinician is going to need to see sort of their standard data and this next to each other, so you develop faith in that. Because I think that's the only way you can really counsel patients and say, this has been my experience with this, which is why they are coming to you. You know?
Yeah, absolutely. So speaking of patients that are coming to you, and you mentioned that you do a rural clinic that's a little bit different than what your standard is. So you already alluded to earlier that when you have a patient who maybe didn't show up, or you're trying to get them to, you'll use something in lieu of a cystoscopy, or maybe mail them a CX kit, something like that. Anything else that you do sometimes with those patients as opposed to just getting them in? Do you change intervals based on patient considerations? What makes you comfortable to stretch somebody out a little bit versus say, look, we're going to be really strict with you. You have to come figure out how to get here.
We talked about that a little bit at the beginning. I mean, you know, patients with low-grade disease, I really tend to think those patients are, you know, okay to go a little bit longer. And so if they're coming from hours and hours away, if they have a negative initial first cystoscopy after their initial disease, that's one of the best predictors of recurrence. And so I will always try to do that cystoscopy on time and really stress that. But after that, you know, I am very quick again to go to like a 6-month interval. I mentioned the sending a CX, but I don't want to pretend, like, I don't think that's what we should be doing.
I don't think the data supports us doing that every time. I think it's something nice to have when you're in this scenario of, we're clearly not doing what is in the guidelines right now. Let's do something else.
Yeah. But I think, you know, to be practical, I do think, you know, something can be better than nothing. Yeah. Obviously, you know, monitoring patients in some way is better. And so, you know, I certainly tell the patient what the recommendation is. You can only do what you can do.
No, I agree. I think that's definitely something that we all struggle with clinically, and we try to convey that this is a lifelong disease to our patients and build that trust that we're going to be doing this together and going through all of that. There's only so much that we can do.
I think it's funny, your language that you mentioned, because I use the exact same language with my patients. I'm like, so we're going to have a very long relationship. You're going to hear all about my kid. You know, I'm going to know about your grandkids. And that's one of the best parts of non-muscle invasive bladder cancer.
I agree.
Absolutely. I want to spend the last little bit talking about your hopes for the future. You know, where do you want to see our bladder cancer diagnostic paradigm shift to? We sort of talked about this a little bit. We want more molecular data. We want to incorporate something besides just pure pathology, pure staging, histology data. What do you think we're going to see in the next 5 to 10 years? What do you think is within reach?
I know we're starting this effort. I know a couple other people were starting as well, but we're creating a bank of cystoscopy recordings of different tumors, and we're trying to go back later and use AI to kind of understand what tumor this was. So we've limited it to treatment naive, new non-muscle invasive tumors, and the idea is can AI somehow predict, is this a T1, a TA, or a CIS tumor? And potentially, is this a high-grade or a low-grade tumor? The problem is obviously you need a lot of data, a lot of compute to do this. And, you know, you'll need a lot of partners and money. So we may not get very far. But I'm sure there's going to be some institution, some group that is going to basically leverage AI to tell us as soon as we're done with the office cysto that this is what the likely tumor is. There was some data of using endoscopic ultrasound, which I think Seth Lerner was involved kind of in those trials where they basically use an ultrasound and you could sort of look at the depth of invasion at the time of cystoscopy. So I think we're going to have some great tools that will tell us when we look in someone's bladder what we're dealing with. And maybe even telling us, this is an inflammatory bladder versus a bladder that actually has cancer. But I'm excited about that. I think there's a lot of potential for that.
And Jill Yao at Stanford, I think, has published
doing it, yes.
on that and beautifully. I think that's a very exciting, interesting direction for sure. And what about you? What's your dream?
Well, I would agree with those things. I mean, my dream is that we can not give patients such vague answers. I would really like to be able to treat a patient up front with what they need. I agree. I think that, with technology, being able to do better depth analysis in the clinic would be phenomenal. I mean, that would answer so many questions kind of right off the bat, right? Save a lot of heartache for patients in terms of wondering where they are, maybe save re-TURs, taking, multiple trips back to the operating room to get this information. So I think being able to better stage is going to allow us to better treat, right patient, right treatment, right time.
Yeah, and I think even, omitting cystoscopy, if we can eventually do that with a combination of technology and maybe biomarkers. So I think if we get to a point where, I'll have patients say to me, you can diagnose other things with a CAT scan. Why can't you diagnose bladder tumor? Why do you have to look in my bladder?
Well, and to our conversation earlier, really like better MRI, staging or other modalities that we don't even know about at this point, where we can really get that information and stage the lymph nodes without having to say, do we need a lymph node dissection if they're radiographically negative, better imaging agents. Look how much we've changed our practice with PSMA, right? It's completely revolutionized how we approach those patients and what we know about their microscopic extraprostatic disease, and I think we're a little behind in our ability to do that in bladder cancer right now.
But I think there's so much excitement and enthusiasm for bladder cancer now than there ever was. I think that we're in a really good spot to make some of these changes and have the industry partners to help us bring about a lot of the stuff that we're looking for.
Absolutely.
This has been such a lovely conversation. I learned so much from both of you. I know our audience has as well. Thank you so much. And thank you for listening to BackTable.
Thank you.
Thank you so much.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.